Joining now. So welcome to anybody joining. We'll just wait another minute or two for others to join before we get started. I think a couple of people still joining, so we'll get started in a minute. Okay. All right, I think maybe we will just get started now. So hello everyone and welcome to the Wolfson Centre Clinical Seminar Series. So I'm Olga Eyre, I'm a Clinical Research Fellow at the Wolfson Centre for Young People's Mental Health at Cardiff University, and I will be introducing our speaker today. Before I do that, I just wanted to let you know that today's seminar will last an hour. So we're aiming for a 40-minute talk followed by 20 minutes for questions and discussion. And if people have questions, if you could post them in the Q&A box during the talk or after the talk, and you should be able to see that at the bottom of your Zoom screen. Yeah, so that's the sort of instructions. And so, yes, it's my pleasure to introduce our speaker today. So Professor Cathy Creswell is a Professor of Developmental Clinical Psychology at the University of Oxford. She is an NIHR Senior Investigator, Fellow of the Academy of Medical Sciences, and Honorary Consultant Clinical Psychologist. She leads the Oxford Psychological Interventions for Children and Adolescents Research Group, and her research mainly focuses on development, maintenance, and treatment of anxiety disorders in children and young people. And today she's going to talk to us about increasing access to psychological treatments for child anxiety problems. So thank you very much, and I'll hand over to you.
Great, thanks very much, Olga, and thank you very much for having me. I would just put up my screen. Hopefully you can see that.
Yes, I can see it.
Lovely, thanks a lot. Great, thanks again. Yes, thanks again for having me. So I'm going to be talking about some of our recent work that's been focusing on finding ways to increase access to treatments, psychological treatments for children with anxiety problems. But just to flag this up before we start, there we are. So the reason I'm focusing on anxiety disorders specifically is really that they're very common. And there's now been a wealth of evidence that really shows the longer term impacts of anxiety problems in childhood on children's life as they go into adolescence and into adulthood. And the work that I'm going to be talking about today is specifically focused on pre-adolescent children. And the reason for focusing specifically on them is because anxiety disorders have a particularly early age of onset. So on the graph here, you can see age of onset as plotted across a number of different research studies. And you can see that while the median age of onset is 15.5, when you look at the median, taking account of people who have anxiety problems starting anywhere across their life course, actually you can see the peak age of onset is actually at the age of 5.5 years. So many people who go on to have anxiety problems will first develop those problems very early in life. So obviously, if we can identify and help to address those problems early, we can really shift the trajectory of those children's lives. So just to go back to the point about the widespread impacts, we were involved in a systematic review with colleagues led by Jack Pollard, which looked across the literature. And as you can see, there were a really wide range of negative outcomes that were identified with childhood anxiety problems. And here you can see the darker coloured ones are the ones where we had stronger support with less frequent strong evidence as we go down, but certainly some evidence for all of these things here. So anxiety problems are common, but of course, one of the problems that we have is that really it's only a minority of children who could benefit from treatment for anxiety problems that reach help. So just looking at data from England, first of all, in England, there is some quite useful data we can draw on. And from that, we can see that of the almost 1.5 million children who were estimated to have a mental health disorder in 2020, 2021, it was certainly the case that at least half of those had no contact at all with any sort of mental health provision. And actually only a third had 2 or more contacts. So actually 66% or so either had no contact or just had 1 contact to support their mental health. And I was digging around trying to find equivalent data for Wales, and maybe when we come to the Q&A you might be able to tell me a bit more about it. But what I did find was some news articles from last year really highlighting how there'd been increasing waits for mental health services in Wales during the second part of last year. So really keen to have your thoughts, but certainly wherever I go and talk about this topic, I tend to find that, well, I haven't found a region that's really cracked this yet. And actually it seems all around the world, people are struggling with the same issue of limited access to mental health support for children who would benefit from it. And here we're obviously going to be focusing on pre-adolescent children. And so I think, in fact, the sorts of data that we just looked at could well be an overestimation of how things are for those pre-adolescents, because actually where people have looked at service use for children as opposed to adolescents, they tend to find that service use is somewhat higher amongst adolescents than children who have mental health disorders. So actually these sort of already quite low access figures are probably higher than it actually is for primary school age children. And another really important thing to take into account in all of this is that this is just about children getting something. And in most cases, we don't actually know what that is and whether what children are receiving is actual evidence-based practice. So when it comes to anxiety disorders, I'm sure you're all really familiar with the evidence for CBT for anxiety disorders in children and young people. We were involved in a systematic review and meta-analysis to update the Cochrane review a few years ago. And in that, we sort of replicated the previous finding that there is good, strong evidence that CBT is effective compared to waitlist controls. In that study, we did look at other types of treatment, so treatment as usual provided in clinics, but also control treatments that were active, where to control for the amount of time that someone had with a therapist. There was a lot less evidence, but some evidence to suggest benefits of CBT over those active controls as well. So whilst there's obviously room for improvement among that, there also is clear evidence that we have treatments that are effective. And but one big issue that we face is that very few children are accessing those treatments. So this is my colleague Tessa Reardon, who did a really in-depth study a few years ago, where she went round the country, England in this case, and recruited children by screening through schools, and then where children screened positive for potential anxiety disorder, she followed up and did full diagnostic interviews and then assessed the access those people had to mental health support. And apologies, I just spotted there's a missing P there, but you can see that just over 60% of those children had tried to seek professional help. In many cases, they'd contacted school staff in order to do that, and under 40% had contacted their GP. And as you can see, under 40% received any sort of professional support. In most cases, they had some support from school staff. Very few had support from mental health specialists. And you can see that a number received counselling. And it was actually only 2% of children that received CBT. So that is the sort of one treatment that we have that has a robust evidence base. So you just need to imagine any other health condition and say 2% of children had the evidence-based treatment, and you can see really how striking those figures are. I apologise, that slide seems to be littered with typos that I will sort out later. So it's really interesting. So obviously you could see there that there are lots of potential barriers to people reaching evidence-based support, but you would have also spotted that there were a reasonable number of families where their child had a diagnosable anxiety disorder, but where they hadn't sought any kind of support. And so Tessa also explored what the barriers were in those cases that might get in the way of people getting some support to help their child. And these are some of the most common barriers that were reported. You can see here that about 64% of families whose children were experiencing problems with anxiety said they hadn't sought support because they didn't want their child to think they had a problem. They wanted to be able to manage their child's anxiety as a family. Was over half of the families questioned responded in that way. About half said they felt a sense of failure or blame as a parent, and that also was a barrier to seeking help. And also that they didn't want their child to be labelled. So it's really important that when we're thinking about how we increase access to psychological therapies for children and families, that we don't just make our treatments accessible, but we do it in ways that's going to overcome these particular barriers that families might face as well. So recently we've had a number of opportunities, and so I'm going to focus on England here, and I'll be really interested to hear from you about whether there's any similar sorts of programmes going on in Wales. But over the last few years, since 2018, we've had the development of 2 new workforces supported by the NHS, the Education Mental Health Practitioners, or EMHP, and Children's Wellbeing Practitioners. And these are psychology graduates who are trained to deliver brief evidence-based interventions for mild to moderate mental health difficulties, specifically focusing on anxiety, low mood, and behavioural difficulties. The education mental health practitioners work in schools in mental health support teams, so they're reaching children and young people directly through schools, as well as providing wider support to schools on mental health. And according to the NHS figures, that they've already increased the number of children and young people seen by more than 70,000 per year. So we have a new workforce, but this workforce are trained to deliver brief interventions. So the next thing we need to do is to make sure that we have brief interventions that are evidence-based, that can be delivered by this particular workforce, that brings such potential to increase access. So a starting point for this is looking back at that Cochrane review that I mentioned before. Now, there's obviously lots on this slide, but I just want to draw your attention to the blue stars down the side. So essentially what we did in this review is we organised the randomised controlled trials that were included in the review, all treatments of CBT treatments for child anxiety, and we organised them according to the amount of therapist contact that was provided. And you can see at the top section, all the studies to the first blue star was where there was less than 10 hours of therapist contact. The middle chunk, down to the second blue star, is where therapist contact was between 10 and 20 hours. And then the final chunk at the bottom, down to the final blue star, is where therapist contact was greater than or equal to 20 hours. And the thing to draw your attention to is that these diamonds here show you the size of the effect, and their distance from the line it tells you exactly how big of a treatment effect there was. And what you can see is if you look down, that those diamonds are in pretty much exactly the same place. So what that means is, regardless of the amount of therapist contact time, the treatment effect was very, very similar across these trials. And you might say, well, that's surely because people are offering longer treatments to children who need longer treatments. And so you're dealing with different sorts of characteristics of participants in these studies. But when you look at the studies, you can see actually that doesn't seem to be the case. You see very similar levels of severity, for example, and comorbidity across these different trials. So what this might suggest is that actually, if we want to increase access to psychological therapies, we can do so by just making sure we're delivering our treatments in the most efficient way. And actually, that may not compromise the treatment outcomes that we're getting. So, just to pop back 1 second there. Oh, there we go. Sorry, there we are. Just to pop back there. One other thing just to mention is that in this top section, where therapist contact was less than 10 hours, where these studies were with pre-adolescent children, one of the important things to highlight is that those treatments were typically delivered through parents and took a parent-led CBT approach. So just to spend a little bit of time talking about what that is. So when we talk about parent-led CBT, what we're talking about is a way of working where the therapist is working with the parent rather than working directly with the child. And the reason to do that is really one of efficiency. It's about being able to help parents to implement strategies in their child's day-to-day life. And you can use a kind of guided self-help type approach when you're working with parents in a way that you might not be able to do when you're working with young children. So the child doesn't need to attend the appointments. So the child can just go about their usual business, going to school if they're at school, doing other things that they might do. And importantly, thinking about those barriers that were raised before, there's a lot less chance for parents to be concerned about children being labelled or made to feel that they have a problem, which obviously we saw can be a real barrier to help seeking. And the aim of parent-led CBT is that you have a therapist who's guiding the parent throughout the process and empowering the parent to learn CBT tools and techniques, which they can then apply in their child's day-to-day life. And so certainly in parent-led CBT, as we deliver it, the core values that underlie this are that parents are the most important agents of change that we can access in helping children to overcome difficulties and anxiety. So it's really essential that we value them and help them feel skilled and confident in managing their child's difficulties. And that really underpins everything that we do in this approach. So the key principles, as you picked up there, are really about empowering parents, helping parents to create opportunities for their children to test fears in manageable ways, having a treatment that's very structured, so it's very easy for parents to then know what to do, to apply it, to be able to hold on to that beyond the treatment. And it's also very goal focused, so focused on the specific things that families would like to see improved in their lives. The approach is very much built on promoting curiosity, so helping parents to explore their child's fears, helping parents to work with their children to explore what their child needs to learn to overcome their fears, and then sort of exploring different strategies to get to that point, and very much taking a problem-solving stance. So the therapist is there to support the parent and help them to implement strategies, helping them to solve problems along the way, and obviously helping parents to be able to do the same for their children. So one of our first trials of parent-led CBT was a randomized control trial led by my colleague Kirsten Thirlwall. And in this version, we had a version that we called full and a version that we called brief, but they were actually both pretty brief. The brief version was just 2.5 hours of therapist guidance, and the full version was 5 hours of therapist guidance. So in both conditions, families were given a book to work through, and then a therapist met with them and spoke to them on the phone to help them work through the programme over about an 8-week period. And as mentioned, the therapist there is encouraging the parents to work through the manual, rehearsing key skills with them, and helping them problem solve challenges that arise. And basically what we can see from this plot is that for the full guided CBT, you can see the effect size here in a square, and the error bars don't cross over the line here that denotes the line of no effect. So that shows there was clear evidence of effectiveness for the full 5-hour version. And that was true across a number of outcome measures, although it was less clearly the case for our 2.5-hour version. So we tended to stick with the 5-hour version. Although when we look at the longer term outcomes, you can see that by the longer term, it looks like the 2.5-hour version tends to catch up. So what this translates into is that immediately after the 5 or 2.5 hours, you get these kind of outcomes. So about half of the children being free of their primary diagnosis. So that's actually very similar to what we get in the Cochrane review from much longer treatments. And then that's a bit more like 40% for the 2.5-hour version, but with over 75% being free of their primary diagnosis by the 6-month follow-up. And you can see when we look at this more global measure of clinical improvement, you can see a similar sort of pattern. So one reason that we've stuck with the 5-hour version is that we get a quicker effect, but the other is that we also saw a hint that there might be some differences in effects depending on who was delivering the treatment. So when it came to the 5-hour version, it looked like it didn't actually matter who delivered the treatment in terms of whether that was a sort of experienced therapist who'd had previous CBT training, or whether it was a complete novice who was trained to deliver this treatment and received supervision. Whereas the data suggests that with the 2.5-hour version, the novice therapists were not getting such good outcomes in that scenario. And so obviously we want to make the most of this new workforces that we have available, really make the most of psychological graduates to deliver these kind of treatments. So for that reason, we also stuck with the 5-hour version. And we went on to do another trial in routine clinical practice across Oxfordshire, where we looked at the clinical and cost effectiveness compared to solution-focused brief therapy, and essentially found, as you can see here, a really high likelihood of parent-delivered CBT being cost-effective compared to solution-focused brief therapy, even though they both got good clinical outcomes. But the cost effectiveness really supported the parent-led CBT approach. So we were very aware in doing this of a number of limitations. One is that this treatment involves giving parents a book to work through, and that's definitely not going to be accessible or engaging for everybody. And it might feel like quite an overwhelming amount of material for people to work through. We also were aware that 5 hours of time with a therapist is still quite a lot for a lot of parents to manage. If you're working, you've got childcare, you've got lots of other demands on your time, that is still a lot of time to make. So what we wanted to do is to really think about how we could make this as efficient and accessible as possible, but without losing the potential effects that had possibly come with the book-based version by just making it a briefer treatment. So with my colleague Claire Hill, we went through quite a substantial co-design project working with parents of children with anxiety disorders, with children themselves, with NHS clinicians, and with a partner tech company to develop an online version of the treatment, which is called Aussie, Online Support and Intervention for Child Anxiety. And Aussie basically is a way of delivering parent-led CBT, but where the online platform is really doing all the heavy lifting. And what the therapists are there to do is to have brief telephone calls throughout the programme just to keep parents going and help them individualise the content and to problem solve any things that come up. So basically, the idea is therapists are really doing the things that only therapists can do, and everything else can go into the programme. And it's got some really nice features that help it fit well within our NHS services. So, for example, with every module starts with parents having to complete routine outcome measures, which means we can capture all the treatment outcome data within the platform. So it means you've got 100% data completion from everyone who participates. Also, you can see here on the right-hand side, this funny little monster. One of the things that came up in the co-design was that families said to us, well, we don't really want another separate platform for our children to work through. It's just another thing to get them to do and to have a battle about. But what would be really great is if we can have something that just helps motivate our child to have a go at new things and try things out, get some new learning. So we worked with a group of children to develop a game which basically provides a way for parents to motivate their children and reward them for having a go and trying out new things. So there's a little monster, you have your own character, and parents can go in and give coins, which children can then use to do fun things within the game. Other things just to mention about the platform is that everything has an audio accompaniment, so everything can be accessed without reading. And there's also various videos and case studies and animations, really just to try to make the information as accessible as possible. So we fairly recently finished a randomized controlled trial called the COCAT study. And COCAT was based in clinical services all across England, and we also had some sites in Northern Ireland. And you can see here we included a real mixture of different sorts of services providing child mental health support. So that included NHS trusts, in pink, charities and independent services that were providing services on behalf of the NHS, and also local authority teams. And as you can see, we had a really nice geographical spread of recruitment across that study. This just gives an overview, but essentially the summary is that we had 444 families who were recruited to the study through these clinical teams. And these were all children who had been referred to child mental health services, and where child mental health services had determined that there was an anxiety problem, and that's what they were going to offer treatment for. And once that had been identified, families then were invited to the study, would consent and would be randomized either to Aussie, the online therapy plus therapist support, that's the Aussie plus TS, or to CAMS treatment as usual. And so that would be whatever the CAMS teams were otherwise delivering. So really important to highlight that these are people who are in the system and who are getting treatment. So it's not treatment as usual means nothing. They were randomized at the point at which they were about to start treatment in these services. So also really useful opportunity to learn a bit more about what treatment as usual in these services looks like. We follow people up at 14 weeks and also at 26 weeks. So just to tell you a bit about who was in the study. So the children were all between age 5 and 12. 90% were white British. You can see that a reasonable number had had previous treatment for anxiety or other related difficulties. And you can see a bit more about the demographics there. And the sample did include families who were living on particularly low incomes. Something that was really useful to see was the professional backgrounds of the different people working within the services. And actually, we can really see the impact of these new workforce schemes that I mentioned earlier, the education mental health practitioners and the children's wellbeing practitioners, because they really did dominate the workforce that got involved in this trial, either EMHPs, CWPs, or trainees of those made up the vast majority. But you can see, other than that, there were also a really wide range of other professionals with different sorts of backgrounds who were working in these services. And essentially in this trial, it was very pragmatic. We just said, if the clinician is someone who would be providing treatment for anxiety, then they can provide it in this trial. So it's a very real world trial that we delivered. As I mentioned, another thing that's really useful about this was it was an opportunity to find out, well, what treatment as usual looks like at the moment in these services, because actually there was a study, it was over a decade ago now, led by Paul Stallard, which explored the use of CBT in children's mental health services in England, and at that time found very few children were being offered cognitive behaviour therapy for things like anxiety problems, and there was very little training, people who were trained to do so in CAMS services. So bringing in these new workforce really seems to have transformed that. And we found that 85% of the children had CBT as treatment as usual. And actually, in all cases, that involved parents, and in some cases, it involved children too. And then you can see there's a range of other therapies that came up now and again, some of which will have overlapped with CBT. For example, when people described an eclectic approach, and some elements of brief solution focused therapy do also overlap. So a bit of a mixture, but the vast majority of families receiving CBT. And that did fit with our expectations, and that was why we set this trial up as what's called a non-inferiority trial. So we set this trial up to ask the question of whether we could increase the efficiency of treatment using the online platform without compromising children's outcomes, clinical outcomes. So we're really hoping that children would get good outcomes in the child mental health services, but that we could deliver the treatment more efficiently using this online parent-led CBT approach. So what did we find? Well, when it came to treatment delivery time, that's exactly what we found. The treatment was much quicker to deliver. As you can see, the full time of delivering the treatment was about 3 hours in the Aussie plus therapist support arm. versus just over 5 hours in the CAMS treatment as usual arm. So still actually quite brief in that arm, but much briefer in the Aussie and therapist support arm. And one thing that I think is worth pointing out is that in this trial, we had a large number of therapists across all of those teams, and most therapists only used Aussie once. They didn't have any training cases, they just went straight in. So actually, and based on some other data we've had since, we anticipate this is a bit of an overestimation of the time it took to deliver Aussie, because for these people, it was brand new and they hadn't had the opportunity to become familiar with it. In our trials, where we've had more familiar people, they typically save at least a half hour of those 3 hours, bringing it down to more like 2.5 hours time to deliver the treatment and do all the associated tasks. So we save time. And also we can see from these results that we also did that without compromising children's outcomes. So if you're not familiar with a non-inferiority trial, basically what you're looking at is this red dotted line here. And what that red dotted line shows you, that if your little diamonds are to the right-hand side of that, it means that your treatment is significantly inferior. So it's doing worse than what you're comparing it to. And what you can see is nothing is on the right-hand side of that. So there is no evidence of inferiority. And in fact, the diamonds are actually hovering around this line of no effect, which means that actually the outcomes were really similar across these two treatment arms, despite the fact that we saved so much time in the Aussie arm. This measure here is the Child Anxiety Impact Scale Parent Report, which was our primary outcome. And this is the Child Report one as well, which you can see, if anything, the results slightly favour the Aussie arm, even though the children weren't involved in the treatment. Just to chuck these up to show a very similar pattern across all of the secondary outcome measures. So we looked at wider anxiety symptom scores, anxiety and depression scores, conduct problems, hyperactivity, peer problems, pro-social behaviour, and the general outcome rating scale. And we saw a completely consistent pattern across all of those measures with very similar effects and no evidence of inferiority. And we also did a full health economic analysis to look at the cost effectiveness of using this sort of digitally augmented treatment to increase the efficiency of treatment. And what you can see is, unsurprisingly, given our other outcomes, that in terms of quality of life adjusted years, it was very similar across those two treatments. So this is looking at estimating children's quality of life and how it's going to be affected. But what you can see is, unsurprisingly, there was a significant reduction in the cost of the intervention in the Aussie arm, which was mostly accounted for by the cost of treatment delivery. So what this translates into when you look at the health economics is evidence of cost effectiveness. So in these graphs, when the little dots show you the sort of different data points, and the percentage of dots below the line that goes across the middle shows you there's a cost saving, and the number that go to the right of the line, the vertical line here, show you that those that are more clinically effective. And so basically you can see here that we've got good evidence that this is bringing cost and clinical benefits, and that the graphs on the right hand side show you the probability that Aussie was cost effective compared to the usual treatment, which was mostly CBT, at different thresholds depending on what you're willing to pay for the gains you're getting. But essentially, you know, across all these different costs, over 75% likelihood of cost effectiveness. So it seemed that we could reduce the amount of therapist time required to deliver the treatment without compromising outcomes. And it was also really important to check that families and therapists were also equally happy with these treatment approaches. So we were really pleased to see that for both the Aussie and therapist support and the treatment as usual arms, we saw high levels of satisfaction for both of those arms, averaging 8 out of 10 on a score from 0 to 10, where 10 is a very high degree of confidence that they would recommend the treatment to somebody else. So just in summary at this point, so the time to deliver treatment when we used this platform as part of it was less than 60% of the time taken to deliver usual treatment, with no negative impact on child outcomes, where we saw substantial improvements, no negative impacts on parent satisfaction, which was high, and no negative impacts on therapist satisfaction, which was also high. And we were really pleased that the qualitative work that went alongside this really supported things that we'd very intentionally done during the co-design. So within the co-design, we really wanted to make sure that this was simple to use and accessible for parents, and that it provided flexibility, and that it was built in a way that sort of empowered parents to be able to help their children. So just a few of the quotes here. One of the parents said, "I'm a complete techno idiot. I'm not smart or savvy at all when it comes to tech. And if I can do it, anyone can do it." Another parent highlighted the flexibility and the importance really of being able to fit around parents' busy lives. They said, "I could just log into it any time that suited me. So even if it was midnight and I sat in bed, I could still say, right, I want to get this done now." Or I was washing the dishes and I was listening to it. The fact that I can come back and read the things again, I can download them. That was very good. I mean, these are all features that came from the co-design and parents and therapists' views. And finally, I feel confident enough that I now have the tools that if that happens with anything in life, not just the person receiving the treatment, you know, for myself, for my other child, it's changed my concept on how to deal with life as well. Therapists also highlighted the flexibility and the benefits that they felt there were, both for them and for their patients. So one therapist said, "I can book more cases in and I can be much more flexible with them." So that's been really helpful. Another interestingly said, "I feel like a lot of the responsibility is being lifted from my shoulders because I know the information that the parent has read is good quality, accessible, and I can just check that they understood it." And then another highlighted the improvements versus our previous book-based versions. They said it's so much easier to use than going through a book. You know what the parents have looked at, you know they've had to read that information and that they've digested that information. Before you even speak to the family, you can look at the routine outcome measures. So really highlighting all the aspects that come from the digital side that allow therapists to get very quickly up to speed with what parents have been doing between sessions. So as I highlighted, this was probably quite a tough test of the online intervention. As I mentioned, most people only delivered Aussie once during the trial, so they didn't have a chance to get familiar with it. We also only provided a very brief training. We started during the pandemic, and basically, you know, obviously everyone was run off their feet at that time. So people had a 45-minute PowerPoint and a manual to help them get started, which is really, you know, the absolute minimum, I think. And then also people during the trial, their supervision came from the service that they were in. So the people supervising them may not have had any experience with Aussie at all. We just offered drop-ins for people to join. So that really suggests that we may be able to even, you know, increase the clinical benefits even further by really boosting the training and supervisory side of things. So this work was obviously conducted within a randomized controlled trial. It was a very pragmatic randomized controlled trial, as I mentioned, that was conducted in routine clinical services by clinicians working in those services. But obviously you do sometimes have the constraints of a randomized controlled trial. You know, you've got researchers sort of following things up and chasing things and making sure things happen. So what happens when we just let things loose within clinical services? I suppose one of the other things to say is within a trial, you also have inclusion criteria. So not everyone you might want to offer it to might be eligible for the trial. In COCAT, we had minimal exclusion criteria, but one of them was an autism diagnosis because the treatment hadn't been specifically developed or adapted for autistic children. And what we found is that since finishing recruitment to the trial, we've said to clinical teams, well, you can just keep using it and we'll just look at it as a service evaluation. And we are finding that it is being opened up and offered to a wider range of children and young people. But we've been really reassured to see that despite that, the outcomes have remained really stable at the rate, at least the rate that we got in the COCAT trial, if not in some cases slightly better. So here you can see this is the data from module 1 to module 6, which isn't quite the end of the treatment program, but it's where we have most consistent routine outcome monitoring. And there you can see very substantial improvements in people's progress towards goals. And here, this is the average across 3 goals. So typically people wouldn't be working on all of those things during the treatment itself. So those are really encouraging and really substantial effects. You might be familiar with the SRS. This is the session rating scale. And this is a rating of satisfaction with the therapy session. And parents complete it after they've had each phone call with a therapist. And the scale goes up to 40, and a score of 36 or more is considered to be a good session. And as you can see, the average across both the trial and our current service evaluation project called Aussie Grows continues to be stable above 36. And that's true when we look at it at each session on its own. So it's been really great to see that as therapists have delivered this in routine practice, they continue to get those high levels of parent satisfaction. And then just looking at a couple of other scales, we've got here measure of child anxiety impact and also the revised child anxiety and depression scale. And again, you can see the same sorts of effects that we found in the trial. So we've now got over 1,000 families registered on Aussie outside of trials, just using it in routine practice. And more are finishing all the time. But this data was from the first just under 350. But this provides us with a really fantastic wealth of data to use to keep exploring how the program's going and how we can continue to make improvements. One way we are really looking to try to keep moving forwards is by thinking about how we can get this to families earlier and earlier. In the COCAP study, we worked in clinical services, but we know from a range of studies and speaking to families that many families don't get to that point and would really welcome support at an earlier stage. So we've had 2 large cluster randomized control trials going on recently. One, the MyCat study, which is with children in Key Stage 1, so age 4 to 7. We've been identifying children at risk of persistent anxiety problems and then offering this intervention. And another, ICATS, which is for children in Key Stage 2, for children who appear to have anxiety problems at that stage, but where we basically screen and then provide treatment in a very integrated way through schools. The MyCat study will be published soon, and the ICAT study, we're just finishing our final 2-year follow-ups at the end of this year. So watch this space early next year for more data on that. And one other way that we are developing things going forward is just thinking about broader groups of children for whom this approach might be helpful. And as I mentioned, the one main exclusion criteria in our COCAT trial was an autism diagnosis. And alongside that, we were getting sort of weekly emails from clinicians asking us if we'd adapted the programme for autism, for the context of autism. And so with Jonathan Green from Manchester and colleagues, we got a grant which allowed us to do a really in-depth co-adaptation process where we really identified how the content of the intervention needed to be adapted for autistic children who are experiencing problems with anxiety. And we were delighted that we recently got funding to do a large randomized control trial in clinical services to be able to evaluate this and compare it to treatment as usual. So very much like the COCAT study, but with this adapted version, and specifically for autistic children with anxiety problems. And actually we'll be starting recruitment to that study in the autumn. And I think it sounds like the NIHR may be happy for us to recruit outside of England. So if there is any interest in that and taking part in that, please do let me know. And we've also got other recent studies where we're adapting the same sort of approach for pre-adolescent children with OCD and selective mutism. And so we're really keen to be able to make treatments accessible for as many families as we can. So I'll stop there. Thanks very much for joining, and huge thanks, of course, to the team that did all the work that I've just spoken about today. I'll get rid of my screen share.
Brilliant. Thank you so much for a great talk. We've had some questions coming through in the Q&A box. If others have got them, please add them. So I'll read these out. So the first one is from Jack Airdrie, and he's asking for the slide that contact time didn't make a difference to the effect of CBT intervention. What was the minimum amount of contact time given in the less than 10 hours category?
Yeah, that's a really good question. So we only included treatments that did involve therapist contact. So it didn't involve like self-help, purely self-help trials. So I don't actually know the answer, but I do know that one of them at least was the trial that I mentioned that just had 2.5 hours. And so I suspect that was probably the lowest one there. And as you'll remember, what we found with that was over the longer term, that seemed to get okay results, but not as good as the 5-hour version in the shorter term, at least when delivered by sort of novice therapists.
Brilliant. So the next question is from Maria Loads, and she's asking, what background did the non-experienced therapists have? Was it task sharing, i.e. primary care providers, health workers, or did they have a psychology background? Do you have any thoughts on why there was no difference for the 5-hour intervention, but a difference for the 2.5-hour version?
Yeah, so again, this is from the book-based treatment earlier on, where we had the 2.5 and the 5-hour version. And in that, we had a mixture of therapists. So we had some who were CBT therapists, clinical psychologists, psychiatrists, and then we had some who were basically psychology graduates, often looking to get some clinical experience. And they had specific training in the approach, and then they had regular supervision from a clinical psychologist, but they didn't have that wider clinical experience. So some of them might have been PhD students, some of them might have been psychology assistant type people. Basically, all what they had in common was a psychology graduate. They were psychology graduates. In terms of what made the difference, I think basically in the 2.5-hour version, there was a lot to get through. And so you had to be quite confident and feel very on top of the material to be able to get through it in a way that worked for families and where families could feel listened to, and you managed to get through the core content that addresses the key mechanisms that are being targeted. So my hunch is that's what it was about, that without that experience, it's, you might struggle a bit more to do that.
Okay, thank you. We've also got a question from Eleanor Lynn. So it says, hi, Cathy, this is Eleanor from UCL. I'm curious to know if the parents involved in your studies have anxiety problems too. Obviously, if the parents are anxious, they might impact their kids and make their kids have more severe anxiety and lower the effectiveness of parent-led CBT. Thank you.
Yeah, it's a really interesting question. In our very first study, the one that I mentioned, that I was just talking about, actually in that one, we had a separate trial running in parallel, which was specifically for children with anxiety problems whose parents had anxiety problems. So in that very first study, we didn't actually include parents who had a diagnosable anxiety disorder, because we were thinking, this is a brief treatment, let's really focus on people who've got a really good prognosis. And there had been some evidence to suggest that where parents had anxiety problems, children did do a bit less well from treatment. So our first trial didn't include families where parents had problems with anxiety. However, we then went on to do another a range of studies to really try and understand what we needed to do to optimize treatment in the context of parent anxiety. And what we found was we did a lot of observational work to identify ways that you might see differences in parent-child interactions and so on, and then did a feasibility study to compare our standard parent-led CBT to a sort of boosted parent-led CBT that was specifically about trying to address some of those mechanisms. And it was a really good experience for me, because what I learned from it is what I think is useful is not necessarily always useful, because what we found in that is we added all these extra bits that were basically about helping parents tolerate their children's negative emotions. And as clinicians, we thought, oh, these new bits are really great. We've done a really good job here. And the parents would often feedback that they liked them. And then when we looked at the outcomes, there was absolutely no improvement as a result of adding those extra bits. And what we found was that even in that study, where we had a sample of parents with either an anxiety disorder or elevated anxiety, we still got really good outcomes just from the basic parent-led CBT. And actually, we saw similar improvements in things like measures of parent tolerance of children's negative emotions. And we also saw similar improvements in parent anxiety across those two arms. So what that really said to me is that actually we shouldn't withhold the treatment on that basis, and actually it can be really help parents who are anxious are perfectly able to use this well. And actually, by supporting parents and helping them to help their children, actually it can bring benefits for those parents as well, because one, life is easier because your child's not struggling so much. But also, we've really focused on trying to empower parents and build their confidence and build a sense of, control in their life by working in this way. So since then, we've not excluded any parents on the basis of parental anxiety. And actually in the MyCat study, the prevention study that I just mentioned, in that one we did screen, because it was for children at risk, we did screen for child anxiety symptoms, but also parent anxiety. And sort of a bit of a spoiler for that one, although it's not out yet, is, you know, we also saw significant reductions in parent anxiety there too. So I would say, I mean, with parent and child anxiety, there are a lot of vicious cycles going on. And this suggests that you know, you can absolutely include those parents, and actually you can break that vicious cycle from different angles.
Yeah, that's really interesting. Thank you. And there's another question here from Jack Airdrie. He's written, also maybe related to parents as well. In parent-led CBT, if therapist notices parents may hold unhelpful beliefs or aspects of formulation that could impact on helping a young person to apply techniques, e.g. a tendency for experiential avoidance, are these addressed with the parent as part of therapy?
So it's obviously is a brief treatment, and what the main approach that we take is one of empowering parents and recognizing that the ways that parents are responding to their children are generally there for a good reason, based on their experience of their child. So what we don't spend a lot of time sort of trying to correct parents, but instead what we try to do is to, because we sort of understand that actually the ways parents are responding is often a response to having an anxious child or particular experiences you've had with them in the past. And actually what we're trying to do in treatment often is a bit counterintuitive, really, in terms of you know, how to best support a child. So what we try to do instead is just to give parents alternatives and ways, you know, sort of tried and tested evidence-based approaches, which are very much about, you know, approach rather than avoidance, but in manageable ways. And obviously, you know, parents will have had particular experiences with their children. They might feel worried or nervous about doing these things. So it's all done in a very collaborative way, but also in a very gradual way. We probably work at a sort of slower, more gradual pace than you might if you were working with a child individually, because it needs to be manageable for the parent as well as the child. And I think really importantly, you know, parents need to have that experience of seeing that what they're doing is working, and being able to build on that. So so I would say that we don't address those things directly, but we try to provide, you know, but by providing parents with guidance on sort of tried and tested strategies, that those things happen by themselves.
Okay, thank you. And so Jack's asked another question, and he said, whilst you mentioned that training was quite brief, most therapists would have had some form of training to be in the role they were in and demonstrated some therapeutic competencies to get the job. What do you think the minimum competencies required to deliver the therapy are?
It's such a good question, and it's a very live question at the moment, because a lot of so we're now looking to roll the Aussie platform out much more widely, and so we're working with lots of clinical teams to work out how it would fit best within their regions. And there's a lot of interest in using different sorts of workforces to support this intervention, particularly thinking about workforces in schools. And so there's been an interesting pilot study in the east of England, in Norfolk and Waveney, where the team there have been supporting pastoral support workers in schools to deliver the intervention. And the basis for that is really the idea that you have people who are just much closer to families and involved in their day-to-day lives, and then so by those people delivering the intervention, you can you know, just break down so many barriers that might exist to getting help in the first place. But the pastoral support workers typically they haven't had the training the people working clinical teams had. So this is raising lots of really interesting questions for us about, is this going to be an okay way to go, and what does the training need to look like for that particular group of professionals who don't have that same clinical background. So far it's actually looking really positive and really encouraging, but we are continuously monitoring the data, because obviously we can capture it in Aussie, so it's a really nice chance for us to look at it and benchmark it against other professional groups. And the feedback from both the pastoral support workers and the parents has been really positive, for all the reasons just mentioned. And I guess one advantage is that with this intervention, you know, so much of the content is there. You know, it's not up to the therapist to remember it and communicate it. It's just there. They have a particular role of supporting the parents through it. So I'm hopeful that with the right training and the right, importantly, you know, support and supervision, actually it may be that we can widen this out in terms of workforces further. But there is a really big question there about, well, what is the minimum competency required, and how do we best establish that? And so we're very much in that zone at the moment.
Thank you. Eleanor Lynn has asked, will Aussie be opened to the public outside the UK to download?
So it's not directly available to the public because it's the therapist supported program. So you need to have a therapist who is trained and supported to deliver it. So it's not something that, it's not like an app that a parent can just go and get, you know, because it has to be provided to them by the health service. So at the moment, we're working with a partner company who are really supporting us to make it accessible, focusing on the UK at the moment, and then potentially down the line to go more widely. But at the moment, we just really want to make the most of this work to really try to, you know, enable our health services here to be able to do more with their existing resources.
Okay. And I think there's time for this one more question here, which is from Rhys Bevan-Jones, saying, thanks for the excellent talk. Interesting to hear about the adaptation for those with ASD. Have you considered adapting the programme for others, e.g. with other mental health, neurodevelopmental or intellectual difficulties?
So I would really love, what I would really love is, because we are getting such positive feedback from clinical teams and that they find it easy to use, what I would really love is that we could kind of have a front door to Aussie, and then you could just choose the version that that will work, you know, for as many children as possible, with adaptations made with experts in particular areas. So we obviously worked with experts in autism to do that adaptation. We're doing the same for OCD and selective mutism, and I would love to grow that and to work with experts in other areas where a parent-led CBT approach could be beneficial. So we don't have current plans for those particular areas, but it's definitely something I'd be really keen to do in the future.
Yeah, so there's one last comment that's been left, which says they've got some further questions to ask, but we're sort of getting towards the end of the hour now. Would you be happy to be contacted through email?
Yes, happy to be, but just a warning that my email is like a bottomless pit at the moment.
Okay, this person's left their email address, but okay, I will. Yeah, that's great. Thank you. I mean, there may be time for one more question if this person wants to type it quickly. Might be a bit too much pressure. Okay, thank you so much for joining us and for telling us about all the work you're doing. Yeah, we really appreciate it.
Great, thanks for having me.
Okay, thank you. Bye-bye. Bye, everyone.